You are on your, you can carry on.
Yes, sir. Good evening to the respected dignitaries and my dear friends. As we continue our journey through this Cancer Week event hosted by our own Medicine, we are gathered here today for a journal presentation. And it is with profound honor to introduce our speaker, who embodies the perfect bridge between the clinical excellence and cutting edge research. Today, we are incredibly privileged to be joined by Dr. Karthikeyan Perumal sir, a consultant in radiation oncology. Dr.
Thank you.
Karthikeyan Dr. Karthikeyan Perumal's academic and professional journey is nothing short of inspiring. He completed both his undergraduate and postgraduate medical training at the prestigious Madras Medical College. Driven by a commitment to specialized care, he furthered his expertise as a fellow in neuro-oncology at the University of Wisconsin-Madison. His dedication to the technical precision of his field also led him to earn a master's in health physics from the Illinois Institute of Technology in Chicago. Beyond his clinical practice, Dr. Karthikeyan Perumal sir is a prolific contributor to the global medical community. He has authored more than 30 publications and presented over 52 abstracts to date. His work seamlessly integrates clinical practice with extensive collaborations in both clinical and basic research. We are truly honored to have you with us today, sir. Your presence provides our students and faculty a rare opportunity to learn from a leader who is at the forefront of oncology. Please join me in giving a very warm welcome to our own Dr. Karthikeyan Perumal sir and request you to address the gathering, sir. Thank you.
Thank you. Thank you for the wonderful introduction. So I'm glad that I was invited to this esteemed forum. And yeah, welcome you all. It's a nice evening and nice to see young faces, enthusiastic, energetic faces. So welcome all and let's start the session. Hello,
Yes, sir.
was I
Thank you so
audible?
much. Yes, sir. Yes, sir. We'll start
Yeah,
the
yeah.
session, sir.
Please, please,
This is
please.
definitely a great start to a journal presentation. Our first session will be our very first journal presentation from the Journal Club of Medicine on the topic Epagedostat plus pembrolizumab versus pembrolizumab alone in unresectable or metastatic melanoma by Sriram from the research wing.
Uh, can you see my screen?
Yes, Sriram.
Yes,
Okay.
yes.
Good evening to all the dignitaries present here and my dear friends. Today I will be presenting Echo 301 Keynote 252 study published in Lancet Oncology 2019 by Long et al. It is a phase 3 trial comparing epacadostat and pembrolizumab versus pembrolizumab monotherapy in unresectable or metastatic melanoma. So this study became famous not because it succeeded but because it failed. And sometimes in oncology, failure teaches us more than success. So this study is important for four reasons. It gives us surprising negative trial as it was promised by the phase 1 and phase 2 data. And it highlights the critical importance of randomized phase 3 trials. And it questions the utility of indoleamide dioxygenase 1 inhibition in cancer immunotherapy, provides insights into combination immunotherapy strategies. And moving on to the rationale, indoleamine oxygenase 1 enzyme, it converts tryptophan to kynurenine in tumor microenvironment. So it creates an immunosuppressive environment, which leads to T cell arrest and promotes regulatory T cells. So as in theory, indoleamine inhibitor, that is epacadostat, will be suppressing the T cell, while PDL should be activating the T cell. So in theory, combination should have more efficacy than the drug alone. And phase 1 and phase 2 results showed almost 52% objective response rate in treatment naive melanoma, and it showed a tolerated combination. So this led to the phase 3 Echo 301 Keynote 252 trial to definitely test whether IDO inhibition enhances anti-PD-1 therapy. So the population included patients with unresectable stage 3 or stage 4 melanoma and without any checkpoint inhibitor, and intervention included epacadostat 100 milligram twice daily with pembrolizumab 200 milligram every thrice a week, and control included placebo with pembrolizumab 200 milligram every 3 weeks, and outcome included improved progression-free survival and overall survival with combination therapy. So the study design is it is a phase 3 randomized 1:1 double-blind placebo-controlled trial, and the sample space is 706 patients with a multi-centered international study, and the enrollment was between May 2016 and January 2017, and the follow-up with 12.4 months. So the sample space was stratified into groups with on the basis of their program death ligand 1 status, whether it is positive, negative, or indeterminate, and the BRAF mutation status, whether it's a wild type mutant with a prior therapy or a mutant without prior therapy. And the primary endpoints used were progression-free survival as per RESIST version 1.1 or overall survival, and secondary endpoints included objective response rate, duration of response, and safety. So the patient population characteristic included age of 64 years, and the sample space included almost 60% of the males, and ECOG category 0 in almost 75% of the sample space, and ECOG category 1 in 25.2% of category. So and PDL1 positive was seen in almost 72.5% of the sample space, and IDO1 positive was seen in almost 90%. And the disease characteristics included M1C stage in 62.6% and elevated LDS 33.4%, and brain metastasis is seen in 4.7%, and BRAF mutation in 44.5%. And the eligibility criteria included unresectable stage 3 or stage 4 melanoma, no prior checkpoint inhibitor therapy except adjuvant CTLA4, and measurable disease as per RESIST version 1.1, and prior BRAF or MYC inhibitors allowed for BRAF mutant disease. And exclusion criteria included prior indolamine oxygenase 1 or program death 1 inhibitors, and active autoimmune disease, or patients with untreated or unstable brain metastasis. So the primary results were a surprise, and epacadostat with pembrolizumab showed almost as same as plus pembrolizumab or monotherapy, and the hazard ratio was 1, and p-value is also not significant, and the overall survival is also almost same. So from the primary results, we can see that there is no benefit from adding epacadostat with pembrolizumab, and there is no improvement in the progression-free survival, overall survival, or objective response rate across all subgroups, including program death ligand 1 positive or BRAF mutant or in this subgroup analysis. So the hazard ratio across progression-free survival in the subgroup analysis was done using Cox regression analysis, and it showed that no subgroup was benefited from epacadostat addition, and all confidence interval crossed 1, and which shows the null effect. And the safety, the drug was generally well tolerated, and pembrolizumab with epacadostat almost showed a similar adverse effects in both the sides, and it was minimal additive toxicity with epacadostat and pembrolizumab, and most common treatment related adverse effects included rash, fatigue, pruritus, and higher rate of hepatitis with epacadostat was seen, and there was no death attributable to treatment within 90 days. And the favorable safety profile it show so epacadostat and pembrolizumab showed a favorable safety profile compared to other immunotherapy combinations like nivolumab and ipilimumab. And so why this phase 2 study showed a negative result? So phase 1 and phase 2 data were misleading because it showed almost objective response rate was almost 56% in the interventional group compared to the control group. So it can be maybe due to the lack of small sample size or the lack of randomization in early studies, which may have overestimated the study power. And IDO1 may not be the right target. IDO, so we have seen that there is 90% of expression of IDO1 in the participator sample space, but co-expression with PD1 doesn't guarantee synergistic inhibition. So IDO1 expression may be a consequence of immunosuppression, but not the driver. So it is not the right target. So the scheduler dosage consideration included like 100 milligram twice daily dose was selected from phase 1 study, and higher doses theoretically could provide a better target coverage, but safety profile was good, so the dose wasn't an issue. So the strengths of the study included study design. The study design is a rigorous phase 3 randomized double-blind placebo-controlled design, and appropriate stratification by the key prognostic tools like program death ligand 1 and BRAF mutation was elaborated, and the adequate sample space with 98% power to detect hazard ratio of 6.5 was seen, and independent external DMC monitoring was done. And study population included a well-defined inclusion and exclusion criteria with balanced baseline characteristics between both the intervention and control groups, and the representative which represents the real world advanced melanoma population. And the population included international multi-center studies, and endpoints and analysis. Clinically meaningful co-primary endpoints such as primary progressive free survival and overall survival was elaborated, and central independent review of radiographic assessment was done, and there was a transparent reporting of the negative results. And the limitations include that the design assumptions of the early pembrolizumab data, because a study powered with median of the old data showed almost 4.7 months, but the keynote showed only 8.3 months. And indolamine oxygenase 1 expression was assessed retrospectively, and it is not used in the stratification. And only single dose of epacadostat was tested. And the study was stopped early based on DMC recommendation, because the dose was safety, but it was not effective for effective with the combination. So it was unreasonable to proceed the phase 3 trial, and it was stopped by DMC recommendation. And no biomarker for the patient selection was used. So implications. So this was the first large negative study of immunoagent and anti-program death one was used, and emphasizes need for rigorous phase 3 validation, and promising phase 1 phase 2 data insufficient for practice changing decisions. And IDO1 inhibitor development. So multiple IDO1 inhibitor programs halted after ECHO 301, and it raises a question about IDO1 as a therapeutic target in cancer. We need a better understanding of the immune resistant mechanisms, and the clinical trial design prognostic markers like lactose dehydrogenase, BRF, and programmed with ligand 1 inadequate for smaller studies, and randomized phase 2 trials should be considered, and patient selection bias can be dramatically affect a single norm trial results. So in current practice, pembrolizumab monotherapy remains a standard first line for melanoma. No role of indolamine oxygenase 1 inhibitors in the routine practice, and focus on other combination therapy. So future directions, a promising alternative approaches are in development, and positive results are seen in LAG3 inhibitors and adaptive cell therapy. And so the key takeaways from this article is that epacadostat and pembrolizumab showed no benefits over pembrolizumab monotherapy, and high quality phase 3 trials overturned the promising phase 1 and phase 2 data. Indolamine oxygenase 1 inhibition strategy remains unproven in cancer immunotherapy, so it reinforces for the rigorous randomized trial before practice change, and this highlights the challenge of patient selection and biomarker development. Thank you.
Thanks, Sriram. It's a wonderful presentation.
Thank you, sir.
So back to the basics. So what is meant by DMC? You told that DMC stopped the
Yes, sir.
trial. What is the
Yes,
meaning
sir.
of that?
Sir, data monitoring committee, sir. So they actually did the interim analysis in between with based on their events with the progression-free survival and overall survival. So
Okay.
the data monitoring committee will do interim analysis in between.
Okay. And what did they find? They found that this drug is not effective. The dosage is not effective.
No, sir. They
Hmm.
deducted that further exposing the drug was not significant. So it does not show any more efficacy with pembrolizumab alone. Monotherapy show a significant efficacy. It does not show any benefit adding another drug with it,
Okay.
epacadostat. So they stopped that due to ethical issues.
Okay. Okay. So one of the question is then why was it showing promise in that phase 1 and phase 2? What is phase 1 and phase 2, by the way?
Clinical, sir. First, phase 1 and phase 2. They did first phase 1 and phase 2. They did without any randomization, and sample
What is
space
phase
was
1?
very
What is
small.
phase 2? What do they do basically in phase 1? What do they do basically in phase 2? Then why do they go for randomization in phase 3? Any idea? So one of the questions in the audience is why did the phase 1 and phase 2 show positive results. Only because of that they had gone for phase 3. No,
Yeah, sir.
yeah. So how do you defend yourself? What do you
So,
say?
phase 1 and phase 3 does not had randomization, and
Mm-hmm.
there was also not blinding was not there. It was an open label study,
Mm-hmm.
and the sample space also was very small, so it may have overestimated the efficacy of.
Okay. The other question is, yeah, I will answer that. The other question is, why was people with a high ID01 expression were not selected? So they didn't select biologically. They didn't characterize this population. They just gave it to everyone. So any reason behind that? Any reason
Uh,
behind that? Yeah, maybe
uh,
that could be the cause
mm,
for the failure of the disease rather than
yes,
the drug
I have
itself. No,
mentioned that in their
yes, you have mentioned. Yeah, yeah,
limitations. I
yeah.
have mentioned about that, sir.
Yeah. So back, yeah, the meaning of phase 1, phase 2, they're quite different rather than open label. In phase 3 also we can have open label studies. Okay, non-randomized
Okay.
open label studies are possible. Phase 1, to remember easily, phase 1 means, is the drug safe or is the vaccine safe? That's all. Okay,
Mhm.
they give it to healthy volunteers. Okay, not to the any patient. Okay, they give at different doses to find the safety. What is the maximum tolerable dose limit? Okay, is it safe? The second phase 2 is it working? Now they give it to volunteers, deceased volunteers, the patient who is having disease. That's all.
Okay.
There cannot be any randomization. They are finding if it is working or not. That's all. So they would have characterized, probably in the phase 2, they would have characterized the people with more IDU1 expression, and they would have
Mm.
given, and they would have found benefit. And only when you find it is safe, it's working, then only you go for randomization. Okay.
Okay.
In randomization, they found some lot of pitfalls, as you have told. So whatever it is, even with the pitfalls, if you see the heading, yeah, the heading, people read only the heading until conclusion. Okay,
Okay.
so it discourages further research with this human studies with this stat. So that's the problem. Okay,
Okay.
so they should not have done that, but they have done it because there will be
Mm.
several reasons. It's not purposefully or it's not because of carelessness. Any design is any study is designed with so much care. So they
Yes, sir.
would be having their own reasons. So they have done it, but still we cannot say that this epacadostat will not be effective in population. We just don't have data, strong
Okay.
data to defend ourselves to use epacadostat along with pembrolizumab in metastatic melanoma. Okay, and there will
Okay.
be several other reasons. Like the patient population itself won't be good. Like
Yes,
there'll
sir.
be, yeah, there would be uh, the performance status itself will be bad, and the patient would be dying because of so many other reasons rather than the disease progression. So several things are there. Okay. So that is about it, and let's go to what people have asked in the chat. Why pair epacadostat with pembrolizumab initially?
Okay.
Yeah,
So
yeah, okay,
first, on theory, it showed that epacadostat is a IDO1 inhibitor, so that is indoleamine dioxinase inhibitor. So
okay,
it will create a immunosuppressive it will prevent the tumor to create a immunosuppressive environment. So IDO1 is expressed in the tumor and it creates immunosuppressive environment and prevents the action of T cells.
yes,
So
exactly,
inhibiting it will be beneficial. So
yes.
pembrolizumab will help in activation of the T cell and it prevents the suppression. So like in theory it should give a synergistic
Mhm.
inhibition.
Okay, okay.
Yeah.
Yeah, wonderful reply. Let me add on to it. So basically, what
Mhm.
happens is all of us tend to develop cancer cells every day. Okay, our immunity takes care of it. Okay, only few unfortunate people the cancer develops or it's manifest. Uh, Else it get destroyed by our own immune system. We don't need chemotherapy, radiation, surgery, and all. But what happens is in people who develop cancer or who manifest cancer, the tumor is smart enough to produce an immunosuppressive environment. That is, when the T cells comes to kill it, it does not kill. It just stays around the tumor. Okay, so the tumor has its own mechanism to evade the immune system or even kill the T4 cells. Okay, so the action of the entire concept of immunotherapy is to suppress the tumor microenvironment so that the T cells don't get suppressed and the T cells are able to act on the tumor cells. That's all. Okay. The PD-L1 inhibitor. The PD-L1 is nothing but a programmed cell death ligand. Okay. The T cells have the T4 helper cells have programmed PD-1 receptors, and tumor cells have PD-L1. And when they come and get itself attached to the tumor suppresses the T cells by this ligand. So we are giving pembrolizumab, which will block the PD-L1, and the T cell is able to act on the tumor cells rather than get inhibited. So that is a basic mechanism. And this IDO1,
Yes, sir.
yeah, this IDO1 that is supposed to help in the tumor suppress the T cells. Okay, so the idea is if you suppress this IDO1, so it can enhance the effect of pembrolizumab. That is a basic idea, and they found good results in animal studies and also phase 1 and phase 2 studies. So they wanted to try it in a randomized trial, blinded trial. Okay, because of the improper study design, we are unable to now find out whether it helps or not. So that is a problem now. Okay, so that is the. Let me check the question. So would a randomized phase 2? No, phase 2 means phase 2 does not involve any randomization. Phase 2 means it's to study on diseased volunteers. So it does not have any concept of randomization in phase 2. So the first question, why pair epocadastat with pembrolizumab initially? I hope it has been answered. And the next question is, would a randomized phase 2 trial prevented the phase 3 failure? No, there's no concept of randomization in phase 2. And at what point during a trial is it ethically mandatory to stop? And Sriram, any answer from your side?
The DMC committee actually they will do the test to say whether it is significant to continue, whether it is actually beneficial to continue. So
Yeah.
if it doesn't seem to be significant, probability of having a significant result in the future is very less. So they stopped it because exposing it to further toxicity of the patient was not ethical.
Yeah. Good. The data monitoring committee also checks about the adverse side effects. So, or if more number of patients are telling or experiencing adverse side effects in either of the arm, be it placebo arm, be it the real drug arm, they tend to stop the study and they will intervene. Sometimes even placebo can do something. Maybe placebo may have, or the drug we use for placebo may be something different. It may cause adverse effects. So when is it ethically mandated to stop is when there are more side effects are occurring in one of the arms. Okay. So and the interim analysis shows more toxicity rather than the benefit, or the interim analysis shows no benefit at all. Then it's ethical to stop the study. So that's what has happened here. Hope that was answered. And the next question is trial designs points. How did they select and stratify melanoma patients by PDL1 and BRAF? And Sriram, any answers?
So they first stratify the groups based on PDL1 expression, whether it is positive or negative, and then BRAF, whether it is a wild type or a mutant without any prior therapy and mutant with prior therapy. And each group they had a block of 4, and in a block of 4 they randomized 1:1. So 2 patient will be have epacadostat with pembrolizumab, and 2 patient will have pembrolizumab with the placebo. And by this, they stratified and selected the patients with randomization.
Okay, good. Good. The thing is, without checking PDL1, nobody starts pembrolizumab. Only if it is positive, we tend to start pembrolizumab. And BRAF, what is BRAF, by the way?
Uh,
Yeah, we have been talking BRAF.
Mm. Yes, sir.
So BRAF is basically a proto-oncogene. It's a serine threonine protein kinase for intracellular signaling pathway, MAP kinase pathway. Okay. So the mutation, particular mutation, BRAF V600E, that is common in melanoma. So that's what we target in melanoma. So that's about it. And yeah, we tend to stratify. We tend to check it. The molecular analysis, we tend to do it, and we classify the patients. And only when the drugs can work, we use those drugs. So the next question is hope that we have cleared it. Any other question based on that? Any other question from your side, Sriram?
Uh, Sir, what do you think like the major limitation in this study, or is there really a limitation, or is this result is like how can we had a positive result of what we would have done?
No, yeah. The limitation, if you see, the numbers are very good. It's difficult to achieve those numbers in that short span of time. It's almost impossible, but they have achieved that number. The only thing is they have not stratified the patients based on IDO1, which is disappointing. I don't know why. They may be having good reasons, but I really don't know why. We need to check with the authors or one of the investigators. I feel that is a major limitation, like not biologically classifying the patients before starting IDO1.
Okay.
Okay, so the next question is IDO1 primary driver of cancer or is it an adaptive response? So, answer from your side, Sriram.
Um,
They're asking about IDO1. Is it a cancer driver or is it just
uh,
an adaptive
it
response
is
from?
not from what I have read. It is not a driver, but it is a result of immunosuppression. From the results what I've derived from the study.
Okay, okay. IDO1, it's not a proto oncogene or MAP kinase or protein. It just helps the tumor suppress the immunity. So we cannot tell it's an adaptive response as well. It just helps the tumor cells suppress the immunity. That's all. And the next question is that the selective inhibition of IDO1 allowed the tumor to switch to TDO pathway to maintain its immunosuppressive shield. So your answer, Sriram.
Uh,
Yeah. The thing is, okay, on your behalf, the thing is, in general, any cell has multiple pathways. So the much fanfare for molecular inhibition, targeted therapies, all those things, they have not. They have given some results, but not to the extent of what we expected, like complete cure of the cancer. Like most cells have multiple pathways. When you block one thing, it knows how to escape that blockade. So it's not just TDO pathway. It would have used several other pathways. We don't know. We need to investigate. So any other questions or anything else, Sriram, to keep the conversation going on?
uh, so mm, so
Yes.
what do you think the future directions from this study will go?
Okay. This study, okay, they'll be investigating. The people who advocated for IDO1, they'll investigate what happened and they'll try to rectify those errors. And
Okay.
they'll try once again.
So
That's
will
what will
the
happen.
IDO1 inhibitor, like the trial will be completely stopped hereafter?
No, 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 not like that at all. Not at all. Okay, they may find it difficult to get the fundings. So that's how it works. That's not. It's not that they will stop it. They'll try getting funding, and they'll try in a smaller population. And when they prove the benefit, then it will be expanded to further larger numbers. Like take 30 patients, randomized 30 and 30. That's enough, and they'll
Mm.
try to find out. And if it is proving useful, then they will expand it, or they'll
Okay.
find what else would have happened, and they'll try to rectify those errors, like better characterizing the patients, better biologically classifying the patients, and they'll try once again. Because a drug, a molecule coming to this extent of phase 3, it's difficult. It takes at least another decade. So whatever molecules are existent, they will not just like that throwing them off. They'll try once again.
Okay.
Any other questions? So in general, okay, somebody has asked. Sir, can I please know, are there any other instances where a drug with a biological rationale? Yeah, there are several instances. For example, in glioblastoma, geftinib. Geftinib was supposed to help it. It helped it. Like in 2014, it got published. Geftinib along with temozolomide. Geftinib is one other tyrosine kinase inhibitor. Geftinib is basically EGFR receptor inhibitor. Okay, and it acts well in lung cancers, head and neck cancers where EGFR expression is very high. Glioblastoma is one deadly disease with expected survival of just 14 months despite treatment with so much of EGFR expression. And it worked in basic science research. It worked in animal studies. It worked in phase 1, phase 2. But when they tried in phase 3, it failed. It failed miserably. It didn't give anything, any help. It didn't improve the survival. Neither it helped in survival, nor it helped in progressive survival. And same in glioblastoma, bevacizumab was tried. It also didn't help. So many trials are there. And most of the studies, they are negative studies in medicine, not just oncology, in medicine. So that's how it works. Finally, only one or two molecules may help. That will come into clinical practice. So many efforts are going on around the world. So many researchers are working, maybe in lakhs, not just thousands. So most of the studies, it will be negative, not just one or two. So it's just an example. Okay. So I hope I answered that. So before anyone asks, so let me keep the conversation going. So in general, what happened is in cancer, they found one of the Japanese researcher. Thank you, welcome. Yeah. So one of the researchers, Japanese researchers, they found that why cancer is incurable. Like for example, there was a time 100 years ago, TB was considered incurable and a deadly disease. Okay? So cancer is even now the same thing. Okay? So when they found the magic bullet, the antibiotics, 100 years ago, not just tuberculosis, even pneumonia was considered incurable, deadly disease. So when they found the magic bullet, like a penicillin or other antibiotics, they cured it. Pneumonia is, even now, a lot of people get pneumonia. Uh, so so after they conquered the pneumonia, they found TB to be incurable or deadly disease. So they found a combination of drugs, 4-drug regimen or 3-drug regimen. They were able to cure the tuberculosis with a prolonged treatment. So the cancer was still mysterious. We have found so many wonderful cancer treatment molecules, drugs, radiation, surgery, better surgery. Um so why still it is not we have not conquered is one of the Japanese investigators, scientists. Um, he found that the cancer has a peculiar way of suppressing the immune mechanism. Like the difference between the infectious disease, be it tuberculosis, be it pneumonia, or even viral disease, HIV, and cancer is cancer cells are our own cells. It's not a foreign cells. In HIV or bacteria or fungal infection, they are all foreign cells. But here, cancer is our own cells. So we thought that because we are unable to tolerate the toxicity caused by chemotherapy, radiation, or even the surgery, we are unable to conquer the disease. That was the general concept. But one Japanese investigator, Tasuku Honjo, he found that the cancer has a peculiar mechanism to suppress the immune cells. So still they found that around the cancer, the T cells are coming, but they are not killing the cancer cells. And mysteriously, they found that the cancer cells express a ligand called PD-1, the programmed death ligand. The T cells have programmed death receptor, and this cancer cells have PDL1, programmed death ligand. And once a T cells come and bind to this T cells, this through the ligand, the cancer cells are able to program the T cells rather than the opposite and kill the T cells or suppress the T cells. Okay, so he found that if we are able to suppress this PDL1, then we can magically cure the disease. It took almost 15 years for him to bring it to practice, the pembrolizumab. Okay, so in 2014 or around 2013 or 14, he was awarded the Nobel Prize, and it came into practice. And since then, in 2014, it was declared that the entire medical oncology will be killed. Means we are going to phase out all the chemotherapy drugs, and we are going to use it, and we are going to conquer the entire cancer itself. But contrary to the much fanfare, still we have not conquered. Still, the pembrolizumab, which are supposed to cure the disease, it gives beautiful response in so many patients. Even in metastatic disease, it gives complete response. The patient becomes disease free. But it is not working in everyone. We still don't know why. So now we are finding out a way to help this pembrolizumab. So many other generation immunotherapy has come. Now we are in fourth generation immunotherapy agents. So pembrolizumab is the first generation. We have come beyond that. So we are trying to add something to help this immunotherapy cure the disease, cancer. But still, we have not found the success. And the efforts will keep going. It will keep going. Because chemotherapy alone is unable to cure the disease. Radiation works in a totally different way. That was supposed to cure the disease, or it helps in a lot of ways, but still it is unable to cure the disease for all the patients. We are unable to use even the word cure in cancer, okay, with any treatment. Surgery, it has its own mechanism, zero order kinetics, but we cannot keep on dissecting any of the tumor that we found out in a new. So the efforts are still on. So the future directions, if you see, it is going to be immunotherapy only, because that's the basic way in which our body can cure the cancer. So we are trying out, finding out mechanisms to make our immunity better. So that is going to be the future direction. Okay, maybe it will take another 20 years or 30 years. We don't know how many. So it's not going to happen definitely in next 10 years. It will take at least minimum of 20 years. So another person has asked a question: did the lack of side effects in this trial actually serve as an early warning sign that the drug was not potent enough to alter the immune system? No, they didn't tell there is any lack of side effects. There was side effects. Even when the drug is not acting on the cancer cells, it will act on the our normal cells, and it will cause side effects. So this drug was having the side effects. So tell about it, Sriram. Did they find any
Yeah.
side effects with this drug?
Yes, sir. Actually, they did find the side effects, but the side effects were similar in both monotherapy and intervention also.
Okay.
But there
So
was
that's
no
what they have
attributable death.
asked. So lack of side effect. Both the arms, if the same amount of side effect means this epocadostat did not have side effect. That's what the question means.
Epocadostat actually showed increased in hepatitis in intervention group, sir.
Okay. Okay. So it did have side effects. It is not that it did not have side effects. It did have side effects. And lack of side effect, we cannot mention as or take it as it didn't work at all. It can still work. Drugs can still work without side effect on the cancer cells. Also, the
Sir,
dose of IDU, yeah. The next question is: if the dose of IDO1 inhibitor was increased, would there be any significant effect? Might be. That's what they will find out in the next. As a next step, they'll be trying to find it out. They'll once again go back to the phase 1, and they'll find out if more more dose can be given safely. So that's what they'll try to find out, and once again come back to phase 3.
Sir, I also had one doubt.
Yes.
So, if the study showed that IDO1, the patient in the sample space actually showed that 90% of them have expressed IDO1. They
Okay.
actually saw that retrospectively after randomizing.
Yes.
So, so, why did the result actually,
Yes.
even though they express IDO1,
Yes.
why did we have seen any results?
Yes. Yes. That's a very wonderful question. The thing is, drug would not have reached the tumor at all. There will be some tumor vascular barrier, just like blood-brain barrier. Initially, they thought once again going back to the glioblastoma, grade 4 glioma. Uh, Most of the drugs don't act. Only found drug is the effective drug is temozolomide, even of as of today. The reason is blood-brain barrier. Most drugs don't reach. So even if we bypass, like giving intrathecally, intraspinally, still they were not found to act. Only gestinib was supposed to act. They found enough drug concentration in the tumor as well as the brain normal neurons. Still, when they put it in a clinical trial, they didn't find any benefit with the gestinib to suppress the EGFR expression. So this epocadostat might be it would not have reached the tumor cells itself, or uh, it it would have reached the tumor cells but would not have acted. We don't know why. We need to find out whether to increase the dose or why it didn't act as it was supposed to act. We don't know. It will be under investigations. There will be several explanations, but we need to find out. They will find
Uh,
it out and they will once again try this same drug.
Maybe it was due to that the tumor is not dependent on this pathway.
Yeah,
It is
no,
already
tumor may bypass, but at least some efficacy should have come, no?
yes.
Yeah, because it just takes means the main drug here is pembrolizumab. Okay,
Mm.
so it should at least help the pembrolizumab, at least to a certain extent. The T cells need only short span of time to kill the tumor cells. Even that it has not helped. Yeah, yeah,
Mhm.
there will be bypassing mechanism. Okay,
Okay.
once we find, they will try to block that also. Okay. Any other questions? Anything else you want to know? So in general, where the recent researchers are uh, the trend is in medical oncology side, it is the more different targeted therapies with lesser side effects and better efficacies. And mostly now the oncology researchers, medical oncology researchers, or in general oncology researchers are focusing on immunotherapy. It's a totally different than the usual medical oncology aspect. Immuno-oncologists are budding up. And better immunotherapy agents, like adding this is a biological agent, pembrolizumab. Epocadostat, it's a small molecule inhibitor. All are immunotherapy agents. So one side, when the direction is on that way, in radiation, it is on rather than photons, they are using heavy particles. Particle beam therapies are the recent trends. So they are using carbon ion, they are using protons, they are using neutrons, boron neutron capture therapy. So research is progressing, and this immunotherapy is a very good combination with the radiation. Okay.
Mhm.
It has given significant effects compared to the chemotherapy when the toxicity is enhanced when we combine with the radiation. This immunotherapy, the efficacy is enhanced. Okay, so immunotherapy is a very good combination with radiation. And surgery, it is advancing in terms of even surgery. There are a lot of researches are going on. It's not just the molecules, pharmacology. Even in surgery, lot of randomized trial will be going on, are going on. Like they are going in for much more lesser radical surgeries. For example, breast cancer. They were doing radical mastectomy. Then they moved on to modified radical mastectomy. Now we are doing breast conservation surgery with sentinel node biopsy. Previously, radical mastectomy means the entire axilla will get dissected, and most patients they will be having lymphedema in that arm, that side arm. Nowadays, we have moved on to breast conservation surgery with sentinel node biopsy. We just do the sentinel node biopsy. Okay, so we are not seeing similar kind of um, lymphedemas in patients. And there are several other recent surgical advances, technical advances are there. Even if we do the lymph node dissections, we are able to still preserve the lymphatic drainage. Several other plastic surgery techniques are there. So, in surgical aspects, so many other advances are going on, researches are going on. With regards to radiation, we are trying to move on to particle therapies. And in medical oncology, we are trying to dump the entire medical oncology, move on to switch it on to or convert it into immuno-oncology. That's where the recent trends are going on. Okay? This is the overall aspect. Any questions? I will be happy to answer.
Sir, so actually, I saw that they actually included patients who had a prior therapy of CTLA neoadjuvant. So why
Okay.
didn't they actually exclude that
They,
CTLA?
yeah, they just want to keep the study simple, like without no other effects. The patient may die of the patient had got exposed to these drugs earlier. Then the question comes: would the patient develop side effects because of the previous exposure or the current exposure? The patient's bone marrow reserves will be different when there is previous exposure to these agents. So they want to keep the study simple so that the results are simple and the questions are lesser number of questions arise. But unfortunately, more questions are arising even after they kept the study simple. So in general, any study they try to avoid patients with a previous exposure to chemotherapy or other agents.
Mhm.
To know the effect of this drug alone, they'll usually the inclusion criteria will be to avoid the patients who got exposed to other agents.
Okay.
So that is the thing.
So how many interim analysis the study will have actually? How many
Interim
times?
usually only one or two, not beyond that.
Okay.
Okay. After starting maybe 6 months or 1 year, they tend to do. And once they find it positive, they are not finding any adverse thing, then they don't do usually till the final analysis. But when more patients are experiencing side effects in either of the arms, they tend to do interim analysis once again. They tend to put a stop and do an interim analysis again. And based on the results, they will be either allow the study to go on or they will stop it.
So this will be already pre-planned when to do.
Yeah, it will be pre-planned along the study design. The data monitoring committee will be part of the study design, and they'll be not the they won't be the data monitoring committee will not be among any of the people in that will be totally different group of people. They won't be part of the investigators, or there will be no relevance or relationships, or the person in the data monitoring committee won't be in any way linked to the people in the investigator group. They won't be student of this person, they won't be the teacher, or they won't even be knowing each other. That's how it is constructed. Any study is constructed so
So
that there
do
is no bias. The investigator always will want to find a positive result, want to get a positive result. See,
so
after 20 years of
during
hard work, they would have now got into this opportunity of trying their own molecule, found molecule. And they always want to get a positive result. And when somebody known to the scientist or the principal investigator is in data monitoring committee, there is a very good chance of influencing them. So they tend to construct the entire data monitoring committee itself in such a way that there is no cross communication or relevance or relationship between these two groups. So it
so
is part of answering your question. Data monitoring committee is part of the study design itself.
okay. So
Yeah. Could the patient's
during that
diet or micro? The other question is diet or microbiome have diluted the drug effects? It can be. In general, in immunotherapy, it's not just a drug alone. The patient gut microbiome also plays a role. Okay, huge researches are going on in immuno-oncology in these aspects, and the diet has an effect on gut microbiota. So it's not diluted the drug effect. It could have affected the immunity itself. So we don't know. We don't know. We need to find out. It's difficult to find, but yes, there may be effect. There is huge relevance between gut microbiota and the tumor response. Okay, that is a recent discovery. So to boost our immunity, if our gut microbiota is good, that itself will take care of any cancer. That is a recent discovery. How to exploit it, we don't know. That also we are trying. So, any other questions? Would you like to know anything else, or you want me to touch base upon anything else? I'll be happy to do.
Yes, sir. Thank you so much for your wonderful review on the research, sir. We understand it much better now. The explanation of phases were very clear, sir, and the doubts of our team were explained so clearly, giving us a sense of clarity, sir. Thank you for sharing your knowledge with us, sir. We still have
Thank you,
some
Ketan.
doubts, like
Yeah,
so
please,
our
please.
research team is planning to start 2 review articles on the day of oncology. So, and sir, you
Yeah,
had mentioned about targeted therapy with lesser side effects, technical
yes,
advances. So, how
yes.
should we proceed about the research or review articles on the topic, sir?
Um, so I can figure out. There are several molecules are there. I can figure out 2 or 3 molecules and ask you to. I can give you topics. Okay, you can contact me. I hope you have the number. You can share my number to. I can share my number to the in the chat itself. Please message me. I'll give you the topics and come back with the results, and I will help you organize those results.
Sure, sir. Thank you very much, sir.
Okay?
We'll message you as soon as possible,
Yeah,
sir. So,
one
and also,
four.
sir, would liquid
Okay.
biopsy be a good domain for research, sir?
Any domain is if you are interested, it will be good for research. Okay, liquid biopsy is also another aspect. Okay, liquid biopsy is nothing but using the blood for analyzing tumor cells are present or not.
Yes, sir. And we are
Okay,
also planning to do in the pediatric age group, sir. Which topic will be relevant to it, sir?
yeah, you message me. You message me. I will pediatric
Okay.
age group. You mean in cancer, pediatric oncology?
Yes, sir.
Yeah, there are several topics out there. Let me see
Okay.
what you are interested or what any particular person is interested, and I will guide accordingly.
Sure, sir. Sure, sir. Thank you, sir, for your
Yes.
amazing insights, and we will work on the amazing topics suggested by you,
Yeah.
sir.
Yes.
So,
Yes. I have messaged my WhatsApp number. You please contact me. I will give you the topics.
sure, sir.
Okay. Thank you, Ketan,
So,
and thank you, Sriram.
Thank you so much,
yes, sir.
sir.
Thank you, sir. Thank you, sir.
Welcome. Thank you all. Thank you
Thank
all
you for
for your
this wonderful
patience and
session, sir.
listening. Yeah. Thank you. Welcome. Welcome.
Yes, sir. Can we wrap up the
Yes.
session, sir?
Yes. And I thank Vignesh also for constantly staying in touch and helping me through this process. And thank you all.
Okay.
Yes, you can wrap up.
Yes, sir. So, as we wrap up this session, I want to extend a heartfelt thank you to our Dr. Karthikeyan Perumal, sir. Sir, your reviews of our journal club presentation were incredibly insightful. It is one thing to present research, but it is another thing entirely to have it reviewed with such depth and clarity. The ideas you have shared today have truly elevated our understanding and given us a much more refined direction for our work, sir. We are so grateful for the time you took to go through our presentation so thoroughly. Your expertise has turned this into a massive learning experience for all of us at Meduscience, sir. Thank you, sir, for your amazing ideas and for constantly encouraging us to push the boundaries of our research. Thank you, sir.
Welcome. Welcome. So can we log out? Yeah.
Yes, sir. Thank you, sir.
Yeah.
Thank
Welcome.
you, sir.
Yeah.
Thank you, sir.
Welcome. Welcome.
Thank you so much, sir.
Welcome.